I would like to introduce our first guest speaker. Very happy to have Dr. Gitlow back. He was kind enough to join us at our first virtual training back in December. And we know from your feedback that everybody found his talk very engaging and informative. Dr. Gitlow is the Executive Director of the Annenberg Physician Training Program in Addictive Disease, which he started in 2005 to ensure medical student access to training that stimulates them to develop and maintain interest in working with patients with addiction. He served as chair of the American Medical Association's Council on Science and Public Health. Dr. Gitlow is the past president of the American Society of Addiction Medicine and serves as their delegate to the American Medical Association. Board certified in general, addiction, and forensic psychiatry, Dr. Gitlow has an active addiction medicine practice. A graduate of the Massachusetts Institute of Technology and the Mount Sinai School of Medicine, Dr. Gitlow's psychiatric and public health training took place in Pittsburgh, following which he went to Harvard University for his forensic fellowship. He now divides his time between his clinical practice in New England and his academic work in Florida. He's on the faculty at the University of Florida. Dr. Gitlow formerly produced programs for ABC Television's online network. Dr. Gitlow is a strong supporter of Oxford House, and he sits on the Oxford House Incorporated Board of Directors. His presentations on addiction to Oxford House audiences at our annual World Conventions have always been met with great enthusiasm and have been very informative, inspirational, and quite entertaining for a doctor. And without having a World Convention this last year, we didn't get our Gitlow fix. So it's great that he's been able to join us for both of these trainings. I will turn it over to Dr. Gitlow.
Well, hi, everybody, and it's nice to be back. I'm aware, of course, that this training, if it had been in person, the plans were to have it in Maui, so I made my background appropriate for that. And I know you can all imagine being there. It would have been a wonderful time, I'm sure. Hopefully things are starting to come together. When we spoke last time, a lot of the discussion was around COVID and the pandemic and how that was impacting both the field of addiction as well as the individuals that we all know and are close to. And I figured it's still time for yet another pandemic update. So I thought I'd put that in here. The first point to consider on the pandemic is that it's given us a talking point. And the talking point is the way in which the country has come together to respond to the pandemic. Now, obviously, we all recognize there have been problems with the approaches. Nothing has quite gone the way it was supposed to. It took a while for us to get the solution in hand. It took a while for us to distribute the solution. It's going to take us a while to figure out what rules we have to follow and how much longer we have to follow them. But we've actually done an enormous amount in just 12 months. And so the question is, if we can do that enormous amount in just 12 months to stem morbidity and mortality due to the pandemic, why have we been unable to do the exact same thing in the opioid epidemic? Why don't we approach that, which is responsible for killing literally hundreds of thousands of people per year, very much like the pandemic? Why don't we approach that in the same manner? Shouldn't we be working just as hard to find a cure, distribute the cure, and diminish morbidity and mortality? And just as in this case, where we've all taken sort of personal hits on whether it's freedom or ability to work or ability to travel, even though we all weren't going to get COVID, by the same token, the population should be willing to take some personal hits, even though they all won't get hit with addictive disease. And my argument with addiction has always been this issue of needing to look at it the same way we look at seatbelts. Not everyone over the course of their life was going to get thrown through the windshield in a horrible car accident. And yet, to prevent the minority who would be so injured, we are all willing to wear seatbelts. And laws were passed to make sure we're all willing to wear seatbelts. In this case, 15% of the American public suffers from addictive disease. Well, that means 85% they don't have it, right? They can use marijuana now and then, they can use heroin now and then, they can use cocaine now and then, They're never going to get addicted. They can take it or leave it, and largely they'll leave it. And because they can do that, their perception is, as with marijuana, that it's a fun drug. I can use it now and again to have a nice time. I don't care if I don't see it for a year or two or three. And then if I do at a party, it's nice. Why not make it legal for everybody? Well, the reason not to make it legal for everybody is the 15% who can't treat marijuana that way. And so as we look at the public response to the pandemic, we need to translate that into a public response for the epidemic, and indicate that we really should be looking at these very much the same way. They're both public scourges. They both cause morbidity and mortality. Both of them can be addressed. We have various treatments available for both of them. So let's make sure that everybody recognizes how many people we lose and so forth. And again, if somebody says, well, COVID kills more people, tobacco use kills 500,000 people every single year. So, COVID is tiny in relationship to how many people we've lost over the last decade just due to tobacco, never mind alcohol, opiates, everything else. So of the two, this is the bigger problem. I can't stand up in a public forum and argue that point, but we know what the truth of the matter is. And I think we've got to take the groundwork that's been done on COVID and translate it so that the epidemic can be looked at comparably. Now, we are making some advances with what's going on in Congress. And in fact, Congress at this point is starting to get the hint that this is, the same kind of thing. And they're looking at doing things the same way. There's a lot in there about block grants and stuff like that. But one of the big things that looks like it might be a possibility is that they will move to maintain some of the newfound abilities that we've got to work with patients with addictive disease over the last year. So a year ago, they passed emergent guidelines that allow us to establish relationships through telemedicine, that allow us to develop and maintain the relationships without the patient ever needing to come into the office. Now, as you all know, right, you're all sitting at home, you've all gone through the past year. You know that some people have viewed this quietly as a net positive, right? For those of us who are introverts, who love being in our homes, who could care less whether we see anybody else each day, we love this. This is great. All I have to do to come to a group of people is turn on my camera and say, hi, everybody, and then I can switch you off when I want to, and without even having all that unnecessary social interaction take place. That's great. So I look at my 17-year-old son, and his grades have gone from a B average to an A average this year. He's been home every day. And I said, why have your grades gotten better? Are your teachers grading more easily? He said, no. There's been a reversal. The kids who were doing are now doing really well. And the kids who were doing really well are now, down in the B and C area. I said, why? He said, well, the people who thrive on interacting with other people, they love the school environment. They do really well there. For people where that's a negative, they do fine at home. Well, it's the same thing for our patients, right? We're sitting here. I have about 135 people on Suboxone right now. I had 136 a year ago. I've only lost one patient. She moved, right, over the past year. This has been the greatest stability I've had with my patient population ever, right? Everybody checked in. Everybody was online on the phone with me every single month. So I've had absolute connections. No one had a car that broke down. No one said, oh, I can't make it to the office today. And if people can't pay for their office visit, I don't care. I still see them anyway. It doesn't take that long, and it's not that, significant. So it's much easier all the way around. And of course, I don't have the overhead that I typically have because there's no office. I'm just sitting at my house. So in many ways, it's good. Where is it bad is, well, they missed the live in-person, going to coffee, getting set up with the AA meetings and so forth. And so for my new patients, and that's the problem, right? When I said I had 136 patients last year and 135 now, and that I lost one because they moved, what that really says is I didn't take any new patients over the whole year. And the reason I didn't take any new patients over the whole year is that, generally speaking, new patients come in because a patient who I have brings them in. They met them at an AA meeting, they met them somewhere, and they brought them to the office. Those people aren't showing up at all. So that's where this whole telemedicine process has cost us. Now, we do have rules in place that allow me to start treating folks remotely. But I don't know how much longer that will still be in place. And that's what Congress is looking at right now, is the ability of continuing the allowances of telemedicine for those patients where it's appropriate and reasonable and it's working for them, while still allowing everything to go back to normal where people can come in on a routine basis. If that happens, we'll have the best of all worlds, and all the patients will be quite pleased with that, and that'll work out nicely. So that's one possible thing coming down the pathway from DC. On COVID specifically, we're starting obviously to get the vaccinations up there. There's 3 available. You're all aware of Moderna and Pfizer, the 2-dose process. Pfizer is one where you get 2 doses 3 weeks apart. Moderna is one where you get 2 doses 4 weeks apart. And now there's the new single-dose vaccine from Johnson & Johnson. You'll see as you read up about it that the Johnson & Johnson has maybe a little bit less efficacy in terms of preventing somebody from getting a COVID infection. But in truth, all 3 of them do very well, greater than 90%, at preventing individuals from having any severe COVID manifestations. So if your goal is stay out of the hospital and keep away from the long-term ramifications of COVID, any of the vaccines will do the trick. And the fact is that all 3 of them will likely prevent an asymptomatic infection. That's what everybody is worried about right now. I hear a lot of discussion around that. Can I actually go out and talk to somebody or shake their hand or spend some time with my elderly mom or do something with my siblings or friends if I've been vaccinated? Or do I still have to worry that I might be the carrier of an infection without knowing it? And again, the truth of the matter is that the likelihood is remarkably low that you're going to have an asymptomatic infection once you've been vaccinated. Vaccination, the term "once you've been vaccinated" applies once you've had 2 weeks since your final injection. So if it's J&J and you're just getting 1 vaccination, you get the shot, you wait 2 weeks, you're now fully vaccinated. Moderna and Pfizer, you wait 2 weeks after the final injection, and then you're fully vaccinated. And if you're fully vaccinated and you want to get together with other fully vaccinated people, you can visit with them. You don't need to social distance. You don't need to wear masks. And if you're fully vaccinated, you can visit with unvaccinated people from a single household who are at low risk for disease because they've been inside. And you don't have to wear masks or physically distance yourself there either, because you're vaccinated. You can't catch it if they happen to have it or are very unlikely to, and you very likely don't have it for them to catch. You can also ignore quarantine and required testing following a known exposure. So you see somebody, turns out they have COVID, but you were vaccinated at least 2 weeks before. You don't have to worry about going through quarantine or needing testing yourself. Feel free to do it, right? Testing is much more available right now. It's available within 15 minutes. There are quick in-office tests for it. And you can feel free, but it's not necessary. If you are fully vaccinated and you're going out in public, you still need to take precautions. You should still wear a mask, still physically distance. I know some states have just sort of thrown that away. Don't buy into it just yet, though, because the numbers still are fairly high out there. And they're as high as they were at a point where everybody was in lockdown earlier in the process. So avoid large-sized in-person gathering, and get tested if you have any symptoms, and so forth. For those who won't get vaccinated, and this is an issue that I'm confronting with some of my patients. Some just don't like getting vaccinations. They have that anti-vaccination belief. I had one fellow tell me, no, I know that the vaccination includes a tracking device. The government's putting it in all of us, and they're gonna know where I am at all times. I said, do you have a cell phone? He said, yeah. I said, the government knows where you are at all times. So go ahead and get the tracking mechanism that they're going to inject, because it's really no different than the cell phone you carry everywhere. He said, okay. And that was, it was my win for the day. So yeah, but in truth, right, there's no tracking mechanism, just to, put a point on that. And then indicate there are some folks who won't get it. Don't waste your time there. Focus on the folks who will get it, and let's keep working at that. We're on course right now for about 50% vaccination by mid-May to the end of May. And that means that we might even have not quite a normal summer, but almost a normal summer, which would be wonderful. And all that's good. So things are going the way we want. One other point on the variants, right? People are worried about the British variant, the South African variant, and so forth. What has happened, generally speaking, coronaviruses like COVID mutate at a rate that is to be expected. Here, what seems to have taken place is that some people have ended up with COVID with a long-term, low symptom infection. The bug gets a chance to grow in these individuals over an extended period of time and can mutate a great deal in that one person. These people become the sources for these new variants. And so what happens is we get a fairly rapid change in what the bug looks like. Moderna has already altered its vaccine to address the variants, and it's likely there are going to be boosters to address variant requirements over the course of the coming year, or 2 or 3. This whole situation, by the way, is not going to end, not the way we all hope it will, right? It's not going to go away. We won't be able to ever say we are done with this bug. It looks like it will become endemic in the population, meaning there will be a variant of it at some level always. Like the flu, for instance. And that we may simply need to include in the flu vaccine whatever booster is going to be appropriate for COVID or whatever it ends up becoming. In the meantime, we also have developed some new techniques for treating folks who do end up with significant disease, should they end up in the hospital. So the mortality rate should drop as time passes as well. And by the end of a year or two, I don't think we'll look at this any differently than we look at the flu. But again, it's not just going to vaporize and go away and not be an issue. So I think that's it with the COVID refresher. Going back to addiction, one thing that continues to be an issue is the lack of coordination between law enforcement and the treatment community. There still seem to be problems with physicians who end up being stopped for prescribing Suboxone to patients, thinking of Suboxone as being a pill mill type of environment. There still are problems where patients who are addicts are stigmatized against both at the pharmacy and by law enforcement, who are saying, they go to doctors and they say, well, it looks like you're just treating addicts. Well, yes, that sort of, just like another doctor might treat people with diabetes, we treat people with addictive disease. But there does seem to be a disconnect that's still in place. I know there are folks working on that. Biden's still working on who's going to be the final candidate for ONDCP, and I think that will be a big help once we get somebody in there with some medical background who can help coordinate law enforcement with healthcare. We lost that a lot over the last 4 years because no real stress was put on ONDCP as being part of the overall package. But I think Biden obviously, given his background, believes in ONDCP and its abilities. So one last thing from Congress is that they are working on more medications coming into play. Now, this brings up again, and this is something that I raised many times, at Oxford House meetings, is this question of what is addictive disease and how do we treat it? I always speak in my lectures as to the fact that we have 3 building blocks of addiction. The first being the genetic abnormality, the sense of discomfort that people have without the drug. And that sense of discomfort is the genetic wrong, if you will. It's the abnormality that we can only address either genetically by fixing somebody's genes, and we can't do that yet, or medically with a medication that addresses the underlying discomfort. And the fact is, the interesting point is that when our patients use drugs, what they are trying to do is treat their underlying discomfort, the genetic abnormality, with a medication. It's the wrong medication, but the truth of it is that the medication actually works very well. That's why they use it repetitively. But the medication has a downside, a negative characteristic of causing rebound in the opposite direction. So a person ends up feeling even less comfortable than they were to begin with, and they begin uncomfortable. So one way of treating the disease would be with a drug that had the plus sides of street drugs without the negatives. In a way, that's what Suboxone is, right? It's got the positives of an opiate without the negative ramifications. But there are still problems. If you stop Suboxone suddenly, you'll experience a withdrawal syndrome. So it would be nice if we had even better medications. The second issue, the second building block of addiction, is the lack of development of a coping skill to deal with the discomfort that they feel because of the genetic abnormality. And that absence of a coping skill, we deal with every day at Oxford House, right? This is what we're best at, is helping people to learn new coping strategies. How do I share my emotions and feelings with other people and not end up feeling worse? How do I find somebody who's going to be responsible and consistent and help me through my discomfort? And that is, it's not a fallback position, it's the second building block. So it's just as important as the first, but realize these are our parallel helping mechanisms. They work in parallel with one another on 2 different aspects of what causes the disease. The third building block is the whole advocacy issue, right? It's the building block that says, if you're uncomfortable because of a genetic abnormality and you don't have a coping mechanism because of some way that you were brought up, you're fine so long as you don't live in a society that promotes drug use. And as you know, we live in a society that promotes drug use rather heavily. I'm going to a Let's Get Clear Georgia meeting tomorrow because Georgia's State House wants marijuana to just be readily available all over the place. They still think it's a medicine, despite the fact that doctors right and left have told them otherwise. We live in a society that loves intoxicants. So if you're uncomfortable and can't cope with the discomfort and you find an intoxicant because it's readily available, you're going to get in trouble. That's the tricky part. So again, now we have three parallel pathways, and the trick to solving our epidemic is the same thing as the trick to solving the pandemic. We needed a vaccine. We needed a vaccine to be readily made available and distributed, and the supply chain had to be there for that, and the doctors to treat it needed to be there for that, and it needed to be made available so that people could make their appointment and go in and get their vaccine. It's the exact same thing here. We need a medicine that addresses the issue if possible. We need 12-step and social environments to be available if possible. And we need advocacy and congressional leadership that assists us in diminishing the availability of the drugs on the street without punishing the individuals who are afflicted or those who would treat them. So to have all three of those running parallel with one another is really what we're looking for. And I know Oxford, as always, is going in the right direction on all of these. So that's all I had planned for today. I'm happy if you have time to take any questions.
We could do maybe a couple questions before we go into break. Please use the raise hand function if you have a question. It's down under reactions, and I'll recognize you and you can unmute. No? He's that good of a speaker. He answered all your questions already.
All the questions.
Yes, that's right.
Perfect. Well, it's certainly nice seeing everybody again, and I'm looking forward to the next World Conference for sure.
Thank you, Dr. Gitlow. We really appreciate it.
Thank you, Paul. Pleasure being here.
Drew Thank you, Dr. Gitlow.
Hi,
Drew
everyone.
has a question.
One question.
Yeah, no, I just had I don't know if it's really pertinent, but you said that we live in a society that really likes intoxicants. Would you consider Suboxone then to be an intoxicant?
No, the question is a good one, and it sort of stems from a question that I asked myself a few years ago. Is somebody clean and sober if they're on Suboxone? And I look at some of my patients. My average patient duration on Suboxone right now is about 7 years. And as I look at them, and they're living their lives, and they have a job, and money's in their pocket, and they're getting along well with their family, and their car's working, and their life is all put back together, I can't honestly say that they're anything but clean and sober. So as I look at those individuals, they're taking their Suboxone the way they would be taking their insulin if they had diabetes. Now, might somebody misuse the drug? Sure. That's always possible. I've had patients who came into the ER because they overdosed with their insulin in a suicide attempt. But that doesn't mean that I should, fault everybody else who's taking their insulin correctly. I have no question that there are going to be some folks who misuse almost any drug. But in general, the folks who are taking it as directed over a long period of time, they're taking it as a medicine, not as an intoxicant.
Right. Thank you.
Great. It looks like we do have a few questions now.
Okay.
So Anna in DC.
Hello, Dr. Gitlow, and thank you so much for coming back. I always get so much awesome information when you share. But I want to ask you, my question is about the last time you were here. So I have to ask you this. The last time you were here, you said you were not going to get the shot, you were going to wait. So what are your thoughts about that now? Have they changed?
I got the shot. I did. And I said I wanted to wait to hear more. I heard more, and I said, nah, the bottom line is just go get it. And I got it. I had a little bit of a reaction after the second one. I was a little bit out of it for a day. I got a little swelling in one of my fingers, oddly, and I have no idea what that was. And that was it. So from that perspective, it was fine. I always, when I give medication to patients, I don't prescribe a medication unless it's been on the market for a year or two. Even Suboxone, I think the first time I prescribed it was 2009. It had been around for a while by that point. So in general, I'm slow on the uptake, but in this case, I just thought there was too much driving on the other side.
Awesome,
right.
thank you.
I'm going to call on you in the order the hands went up. So next is Matt Martella from Arizona.
Hi, Dr. Gitlow. Thank you for speaking.
Sure, Matt.
I was wanting both your professional medical opinion and your personal philosophical opinion on something. When we have members come in who are in early recovery and they have reservations about medical marijuana and abstaining from medical marijuana, what is something that you would tell that person in early recovery about why they should abstain from medical marijuana?
So there's a few things there. The first is that there really isn't any such thing as medical marijuana. If there were, it would be available by prescription and could be picked up at a pharmacy. What we have is sort of this odd, again, parallel structure where legislators have come up with this methodology of making it available through dispensaries that aren't pharmacies by recommendation, not prescription, because in truth, they recognize that there is no medical guideline indicating that marijuana should be used for any medical condition. And so this is, in my mind, legislated marijuana rather than medical marijuana. And since we don't have any physicians who are in responsible places who actually say, yeah, marijuana is good for that, we're not in a position where it's medically indicated, that it meets standard of care, that there are guidelines covering its use. There's none of that. So the bottom line with what I tell my patients is, look, back when alcohol was prohibited, you could get alcohol for medicinal purposes. You could go to a doctor and a doctor could write you a prescription for gin. And you would actually go to a pharmacy with the prescription and pick up medicinal alcohol. And that's where, if you've heard the phrase, yeah, I drink, but I only drink for medicinal purposes, that's where that comes from. That 100 years ago, you actually could drink for medicinal purposes. The odd part of that is everybody knew it was a joke and that, there was no medicinal purpose for using alcohol. And the moment prohibition went away, that whole concept of drinking alcohol medically vaporized. And this whole thing that we're in right now with medical marijuana will vanish the moment recreational marijuana becomes legal. And I think it will, unfortunately, become legal. But the medical concept of it is having a medical purpose, that'll go away right away then.
Okay. Mark Johnson from DC, you had a question?
Yes, thank you, Dr. Gitlow. If you could speak from a professional and a personal perspective on why the length of stay for individuals on Suboxone and methadone or methadone is so long.
So it's a good question. And again, my perception of the disease of addiction is that it is a chronic lifelong condition. That doesn't mean, and again, it depends on how you define addictive disease. Most of the lay public defines addictive disease as being about the drugs. How long are they using heroin? How much heroin do they use? How often do they use heroin? These are the questions people often ask. Even pharmaceutical companies will come to me and they'll say, what percent of your patients were using heroin versus what percent were using pharmaceutical grade opioids? And I tell them, I don't differentiate between the two. It doesn't matter, right? Both do the same thing. How often were they using? How much were they using at each time? None of those things matter with addictive disease because either you have addictive disease or you don't. Well, once you get to the point where you sort of acknowledge that either you have it or you don't, independent of the drug, then comes a question of, when will that disease go away? And it won't. It's like having diabetes or hypertension. You can ameliorate hypertension. You can exercise each day. You can lose weight. You can quit smoking. You can do a bunch of things to help your high blood pressure. But the underlying process, whatever mechanism is taking place physiologically that makes it so that you have hypertension and somebody else does not, that's not going to change. So what we have with addictive disease is an underlying mechanism that's true in our favorite 15% of the American public. And so now comes the question, how long do they need to be on the medicine? Now, if you view it as a crutch, then that's going to give rise to the question. If you view it as, boy, this is a great solution to an underlying genetic abnormality, then you would hope that they can't stay on it forever. So it depends how you look at it. What I tell my patients is the more solid your recovery is, the better engaged you are in 12-step and self-help, the better able you are to get up in front of a group of people and spill your guts, the more likely it is you'll be able to come off of the Suboxone or the methadone and deal with the discomfort that you're going to feel when that happens. And there are plenty of people who can do just that. But what I've always said to myself, first of all, I haven't had a lot of luck getting people off either one. And you know, they get off, they do well for a few years, and then they end up back at my door or worse. So my rule of thumb is do no harm. Well, if they're on the medication and they're taking it every day and they're not having any negative effects except maybe some constipation, that's one side of the scale. And on the other side of the scale is I could take you off, save you the annoyance of the constipation, but maybe you're going to pick up an overdose and die. And even if it's just a few percent who will do that, I'd rather everybody be constipated. So as a physician, my personal preference is they stay on it because that's where they're most protected. But if somebody comes in with, you know, a really good solid recovery, that's the person where I'm willing to give it a try.
Okay. Ryan from Wisconsin, you got a question?
Thanks, Dr. Gitlow. I appreciate it. I was here last time with you. So I have a question for you when it comes to COVID-19. You said it's going to be around here for a while. When is herd immunity going to take over, and what are the advantages of herd immunity?
So herd immunity is a situation where the bulk of the population is either immune or they had it or they were vaccinated. And so the potential for a super spreader event drops to near zero. Simply because if somebody gets it, the likelihood is more likely than not that they're not going to run into somebody else who is liable to get it, right? They'll run into somebody who either is vaccinated or so forth, and it won't spread beyond them. So that's what herd immunity means, is that you've gotten to the point where it's unlikely any one case will lead to multiple additional cases. As to when we reach it, if we continue vaccinating at the rate that we are now, we'll reach that point by the end of the summer. You know, again, that's the goal, but realize that because the bug has become endemic, meaning it's always present somewhere in the population, because the bug has gotten to that point, what it's likely to do is mutate slightly to stay one step ahead of the vaccines, just like the flu does. And of course, the vaccines are going to have a limited amount of immunity associated with them. It's not like polio where you get the vaccine, you're all done. This is one where you'll need a booster in any case. But each year, the booster will be a little different to make up for the fact that the bug has changed a little bit. And again, I assume that the vaccination is going to lead to a roughly 12-month period of immunity. So if that's true, and if indeed it can be combined with the usual flu boosters, then that will be as far as anybody needs to really think about it after this, so long as they get their flu shot.
Okay. Eric from New Jersey.
Eric's muted.
You're muted.
Dr. Gitlow. I appreciate it very much.
Hi, Eric.
Just wanted to ask, you discussed the genetic component of addiction, and you also spoke about COVID, and there was a conversation going on earlier in the year about people who were predisposed to COVID.
Right.
And fortunately for all of us, the development seems to have been in this mRNA delivery of of vaccines. Even though when you speak genetically about the disease of addiction, that's more in the DNA, I believe.
Right.
Is there any hope or potential for the development through mRNA work in the addiction studies?
So mRNA, the way this works, the COVID bug itself has what's called spike proteins that exist on the surface of the molecule. What the mRNA does is it essentially instructs your cells to make spike proteins. It doesn't make COVID. You can't catch COVID from the vaccines. But the Moderna and the Pfizer both instruct your cells to make some of these spike proteins. They go out, they trigger an immune response so that if you were ever confronted with COVID, your body would see the same spike proteins that it's already been exposed to, and it's already prepped to go out and save you from that one. So if the genetic abnormality in addiction were an infectious agent, then mRNA would be a perfectly good approach. At this point, there's no evidence of addiction being infectious. So the approach doesn't work well in addiction, but there are other genetic techniques that might. And so
Couldn't
that's
it be used as an uptake or a receptor uptake instead of allowing the body or the cells to uptake as much to prevent against overdose, perhaps?
right. And again, it's those sort of things that are worth looking at to figure out what is it exactly that's taking place. I've always used metaphorically the fact that somebody's volume knob is misset in their head. Wouldn't it be nice if we could solve that through a DNA intervention? And of course, with all the appropriate caveats that we want to make sure we're not, causing some negative at the same time as we're producing a positive. So there'd be an awful lot of testing that has to happen. But I'd love to see us go in the direction where we have an honest cure for addiction. That would be the best of all worlds. I think it's probably a generation or two off, but I think it's achievable.
Okay, we're out of time, guys. Thank you, Dr. Gitlow, very much for answering all our questions. And we're going to go into our last 10-minute break now. There'll be a couple survey questions that pop up related to the pandemic. And when we come back, we're going to talk some more about doing outreach in the pandemic. So hang in for that, and then we'll be done for the day.